Good morning. My name is Dr. Sandeep Vaghulde, and I am here today to talk to you about social and preventive pharmacy with Unit 3, National Health Programs. In this we will be discussing national health programs, its objectives, functioning and outcome. Total marks allotted for this topic, 24 marks as per the blueprint of University of Mumbai. Various health programs includes HIV and AIDS Control Program, TB, Integrated Disease Surveillance Program, IDSP, National Leprosy Control Program, National Mental Health Program, National Program for Prevention and Control of Deafness, Universal Immunization Program, National Program for Control of Blindness, Pulse Polio Program. We will be covering mainly objectives, functioning and outcomes. HIV and AIDS Control Program outline given below. Introduction. National AIDS Control Program. National AIDS Control Organization. Milestone of the program. NAC, that is National AIDS Control Program, first phase begins with 1992 to 1999. NAC second phase starts from 1999 to 2006. NAC third phase starts from 2006 to 2012. NAC fourth phase starts from 2012 to 2017. Latest National Strategic Plan starts from 2017 up to 2024. Finally, conclusion. We will start with first program, that is HIV and AIDS Control Program. First begin with small introduction. Human immunodeficiency virus, HIV, is a virus that belongs to the retrovirus group, may cause HIV infection, AIDS, acquired immunodeficiency syndrome. It has emerged as one of the most serious public health problems in the country. The first case of HIV was detected in Chennai in 1986 in female sex workers. The greatest speed in the sex high prevalence state of Andhra Pradesh, Maharashtra, Manipur, Nagaland, Karnataka and Tamil Nadu. The goal of the National HIV/AIDS Control Program is to reduce the prevalence of the disease and mitigate its impact on the general population. What is National AIDS Control Program, NAC? The government forming the National AIDS Committee, NAC, headed by the Union Health Secretary. The National AIDS Control Program was launched in the year 1987. What is National AIDS Control Organization? National AIDS Control Organization, NACC, 1992 is an organization of Government of India under the Ministry of Health and Family Welfare with the primary objective to control the epidemic in India. NACO aims at facilitating and improving access to treatment for HIV plus people and also be phased to promote and protect their human rights. Ever since its establishment, NACO has been working to create awareness about HIV/AIDS, giving accurate and reliable information on the menace, clearing existing myths and misconceptions and providing practical skills that can be implemented at the individual's level so as to lead to be changes that minimize the risk of HIV infection. Different milestones of the program. In 1986, first case of HIV detected and National AIDS Committee established by Ministry of Health. In 1990, medium-term plan launched for 4 state and 4 metros. In 1992, NAC first phase launched. National AIDS Control Board constituted. NACO setup. In 1999, NAC second phase launched, SACS established, which states AIDS control societies. In 2002, framing of first National AIDS Control Policy and framing National Blood Policy. In 2004, antiretroviral treatment initiated for first time. In 2006, National Council on AIDS under chairmanship of Prime Minister then National Policy on Pediatric Art. In 2007, NAC third phase launched for 5-year begins from 2007 to 2012. In 2012, NAC fourth phase launched for next 5 year. First phase of National AIDS Control Program, NAC, starts from 1992 to 1999. During these phase, the National AIDS Control Project was developed for prevention and control of AIDS in the country. Objective of the program include slow and prevent spread of HIV through a major efforts to prevent its transmission. Strategies used for the program include to attain a satisfactory level of public awareness on HIV transmission and prevention. To screen all blood units collected for blood transfusion. To decrease the practice of professional blood donation. To strengthen and control of sexually transmitted disease. To monitor the development of the HIV/AIDS. Achievement of the first phase of National AIDS Control Program includes awareness level that were almost insignificant have increased to about 70 to 80% in urban area 7 through the level of awareness in rural areas remain low at about 30%. Modernization and strengthening of blood banks. Introduction of licensing system of blood banks and gradual phasing out of professional blood donors. Availability of good quality condoms through social marketing has made a significant increase in its use. Second phase National AIDS Control Program start from 1999 to 2006. National AIDS Control Program has become effective in 1999. It is a 100% centrally sponsored scheme implemented in 32 state union territories and municipal corporation namely Chennai, Ahmedabad, and Mumbai through AIDS control societies. Objective of the program, to reduce the spread of HIV infection in India through a behavior change. Strategies of the program. To shift the focus from raising awareness to changing behavior through intervention. Prevention among high-risk population. To protect human rights by encouraging voluntary counseling and testing. Achievement of second phase of National AIDS Control Program includes at the operational level 1033 targeted intervention set up, 875 voluntary counseling and testing centers, VCTC, and 679 clinics at the district level. Nationwide and state-level behavior sentinel surveillance, BSS, surveys were conducted. Prevention of parents-to-child transmission, PPTCT, program was expanded. Introduction to National AIDS Prevention and Control Policy. In April 2002, Government of India approved the National AIDS Prevention and Control Policy. Objective of the program, zero transmission rate. Prevent further spread of the disease. Improve services for PLWHA, that is people living with HIV/AIDS. Care of PLWHA, that is people living with HIV/AIDS. Protection of their rights. Proper care and supports in the hospital and community. Keeping confidentiality. Proper counseling of HIV-positive mothers. Clinical management of HIV/AIDS. The National AIDS Prevention and Control Policy, NAC, in India has several components, including prevention of new infections, various treatment, supportive care for control of STDs, that is sexually transmitted diseases, awareness about condom promotion as well as IEC, that is information, education and communication, blood safety, monitoring and evaluation with clinical management, harm reduction. The first component of NAC is blood safety. According to NAC, only licensed blood banks to operate. To encourage voluntary blood donation. Ensure safety in collection, processing, storage and distribution of blood and blood product. Establishment of zonal blood centers. Testing every unit of blood for HIV, hepatitis B, malaria, syphilis and HCV is mandatory. The second main component of NAC is control of STDs, that is sexually transmitted diseases. Integrating service for treatment of reproductive tract infection and sexually transmitted infection. Training of all the medical and paramedical workers engaged in providing STDs RTIs, that is reproductive tract infections services. Hence, early diagnosis and treatment of STDs is now recognized as one of the major strategies to control spread of HIV infection. The next component of NAC is about creating awareness related to condom promotion, which provides details about 85% of HIV infection are due to unprotected sex and multi-partner contact. This can be prevented by constitute use of good quality condom. Progress made by NACO in condom programming includes following segments. A. Quality control of condom by specifying parameters as prescribed by WHO. B. Using social marketing strategy for condom promotion. C. Involvement of NGOs and private voluntary organization in the program. The next component of NAC is prevention of HIV transmission for mother-to-child related to B. Among HIV-positive women, in which 5 to 10 infant will be infected during pregnancy. 10 to 20 infant will be infected during labor and delivery. 20 to 30 infant will be infected during breastfeeding. Prevention includes a short course antiretroviral regimen given to the mother. It can substantially reduce the risk of perinatal transmission of HIV during pregnancy and childbirth. This component of NAC has been started from 1st October 2001. The next component of NAC is IEC, that is information, education and communication related to creating awareness. Information, education and communication is the key to generating awareness on prevention as well as motivation, access to testing, care and supports. Various segments include A. To increase knowledge about general population, especially youth and women, on safe sexual behavior. B. To sustain behavior change in high-risk group and treatment. C. To generate demand for care, support and treatment service. And D. To make appropriate change in societal norms, reinforce positive attitude. The next component of NAC is School AIDS Education Program. To raise awareness level and develop a safe and responsible lifestyle in student youth. State AIDS control societies cover the student of secondary and higher secondary school. University Talk AIDS project cover the colleges and universities. The next component of NAC is Family Health Awareness Campaign. To raise the awareness level regarding HIV/AIDS in rural and slum areas and other vulnerable groups of the population. To make people aware about the services available under the sector for management of RTI/STD. To facilitate the early detection and prompt treatment of RTI/STD cases. To aware that HIV can be transmitted from the infected mother to her baby during pregnancy, delivery and breastfeeding. National AIDS Control Program third phase start from 2007 to 2012. Objective of the program is to reduce the rate of incidence by 60% in 1% year of program in high prevalence states and by 40% in vulnerable states. Strategies of the program includes prevention of new infection in high-risk population group. Provide greater care, support and treatment of PLWHA. To strengthen the nationwide strategic information management system. Prophylactic treatment for HIV, ART treatment. Achievement of third phase National AIDS Control Program includes 306 fully functional art and 612 link art centers, 10 COI that is centers of excellence, 259 community care were established. 12.5 lakh PLIV were registered and 4.2 lakh patients were on art. Link workers training modules updated and condom promotion program was strengthened. 3,000 red ribbon clubs were established. National AIDS Control Program NAC fourth phase starts from 2012 to 2017. The Cabinet Committee on Economic Affairs chaired by the Prime Minister has given its approval for continuation of National AIDS Control Program, fourth phase of NAC, beyond 12th five-year plan for a period of 3 years from April 2017 to March 2020. Objective of the program includes to reduce new infection by 50%, NAC third phase of using 2007 baseline. Provide comprehensive care and supports to all persons living with HIV AIDS and treatment service for all those who required it. NAC fourth phase had several key strategies to reduce HIV infections in India includes Strategy 1. Intensifying and consolidating prevention services. Strategy 2. Comprehensive care, support and treatment. Strategy 3. Expanding IEC services. Strategy 4. Strengthening institutional capacities. Strategy 5. Strategic Information Management System. Guiding principle of NAC Phase 4 includes continued emphasis on one agreed action framework, one national HIV/AIDS coordinating authority and one agreed national system. Equity. Gender. Respect for the rights of the PLIV. Civil society representation and participation. Improved public-private partnerships. Key priorities under of NAC Phase 4. Preventing new infection by sustaining the reach of current intervention and effectively addressing emerging epidemics. Prevention of parent-to-child transmission. Focusing on IEC strategies for behavior change. Providing comprehensive care, supports and treatment of people living with HIV. Ensuring effective use of strategic information at all levels of program. Integrating HIV services with health systems in a phased manner. National Strategic Plan was implemented in 2017 up to 2024. Ensure a more effective, sustained and comprehensive coverage of AIDS-related services. NACO has implemented a 7-year National Strategic Plan on HIV, AIDS and STI from 2017 to 2024. This National Strategic Plan, NSP, will herald the country to the midpoint of the 2030 goals. The vision of the NACO is that of paving the way for an AIDS-free India through attaining universal coverage of HIV prevention, treatment to care continuum of services that are effective, inclusive, equitable and adapted to needs. The goals remain those of the 30 0 new infection, 0 AIDS-related deaths and 0 discrimination which form the basis of this strategic plan. By 2020, the focus of the national program will be on achieving the following fast targets. By 2020, the focus of the national program will be on achieving the following fast targets. The 75% reduction in new HIV infection. Elimination of mother-to-child transmission of HIV and syphilis. Elimination of stigma and discrimination. Implementation of Rule 90-90-90. 90% of those who are HIV positive in the country know their status. 90% of those who know their status are on treatment. 90% of those who are on treatment experience for effective viral load suppression. In conclusion, India's National AIDS Control Program, NAC, has been successful in reducing new HIV infections and AIDS-related deaths following are few things which considered for NAC 5th phase implementation. To reduce the spread of HIV infection in India. Strengthen India capacity to respond to HIV AIDS on a long-term basis. State-level AIDS control societies and improve drug and equipment practice. The National Tuberculosis Elimination Program, NTP, earlier known as the Revised National Tuberculosis Control Program, RNTCP, is the public health initiative of the Government of India to emphasize the aim of the Government of India to eliminate TB in India by 2025. TB in India. TB has existed in India for several thousand years. TB in India around 1500 BC. TB in India is an ancient disease. In Indian literature there are passages from around 1500 BCE in which the disease is attributed to excessive fatigue, worries, hunger, pregnancy and chest wounds. Then from around 500 BCE there are a number of Sanskrit manuscripts which are the texts from which the Ayurveda system of general Indian medical practice is derived. However, the Madhukosa also says that the texts are clear that the ancient disease had a much wider range than TB. Introduction of Tuberculosis Association of India. In May 1939, Dr. Frymont Moller became the association's first medical commissioner. During the time that he held office, three major measures were carried out by the association. These were the establishment of the TB clinic in New Delhi, the creation of the Lady L. Sanatorium at Kasauli, and the formation of a scheme for organizing home treatment as an essential part of India's anti-TB campaign. History of TB programs in India. India has had a TB control program since 1962. Since then, it has reorganized itself two times, first into the Revised National Tuberculosis Control Program, RNTCP, in 1997, and then into the National Tuberculosis Elimination Program in 2020. NTP, also known as National TB Program, implemented first in 1962 up to 1997. TB control efforts got organized with the National TB Program, NTP, primarily focusing on BCG vaccinations as a preventive measure. At that time, the Indian government lacked the financial backing to meet its public health goals. Therefore, external sources of funding and administration, often from the WHO and UN. In 1992, the WHO and Swedish International Development Agency evaluated the NTCP, finding that it lacked funding, information on health outcomes, consistency across management and treatment regimens, and efficient diagnostic techniques. National Tuberculosis Control Program, NTCP. National Tuberculosis Program in 1962, the Government of India launched as a National Tuberculosis Control Program to detect as many tuberculosis cases as possible, provide effective treatment, establish district tuberculosis centers, extend short-course chemotherapy, and strengthen existing state tuberculosis training and demonstration centers. Introduction of Revised National TB Control Program, RNTCP, implemented in 1997 up to 2020. The large-scale implementation of the Indian government's Revised National TB Control Program, RNTCP, sometimes known as RNTCP-1, was started in 1997. The RNTCP was then expanded across India until the entire nation was covered by the RNTCP in March 2006. At this time, the RNTCP also became known as RNICP-2. RNTCP-2 was designed to consolidate the gains achieved in RNTCP-I and to initiate services to address TB, HIV, MDR1B and to extend RNTCP to the private sector. Role of revised National TB Control Program (RNTCP) in India. RNTCP uses the World Health Organization (WHO) recommended directly observed treatment short course (DOTS) strategy and reaches over 1 billion people in 632 districts reporting units. The RNTCP is responsible for carrying out the Government of India 5-year TB National Strategic Plans. With the RNTCP, both diagnosis and treatment of TB are free. There is also, at least in theory, no waiting period for patients seeking treatment and TB drugs. The Directly Observed Therapy (DOTS) strategy is a method of ensuring that tuberculosis (TB) patients take their medications as prescribed. DOTS Directly Observed Treatment (short course) is the most effective strategy available for controlling the TB epidemic today. It's a standard part of TB treatment guidelines and is used worldwide. Here are few given below. 1. DOTS has become a very successful TB control strategy. 2. It has decreased epidemics and new infections in many countries. And 3. It has also lowered drug resistance rates. Implementation of revised National TB Control Program (RNTCP) in India. The initial objectives of the RNTCP in India were to achieve and maintain a TB treatment success rate of at least 85% among new sputum positive (NSP) patients and to achieve and maintain detection of at least 70% of the estimated new sputum positive people in the community. New sputum positive patients are those people who have never received TB treatment before or who have taken TB drugs for less than a month. They have also had a positive result to a sputum test, which diagnoses them as having TB. Introduction of National Tuberculosis Elimination Program (NTP). RNTCP renamed as NTP. At the start of 2020, the central government renamed the RNTCP the National Tuberculosis Elimination Program (NTP). In a letter to all the state chief secretaries of states and UTs, the commitment is emphasized of the union government achieving the Sustainable Development Goal of ending TB by 2025, 5 years ahead of the global targets. Role of National Tuberculosis Elimination Program (NTP). The National Tuberculosis Elimination Program (NTP) is the public health initiative of the Government of India that organizes its anti-tuberculosis efforts. It functions as a flagship component of the National Health Mission (NHM) and provides technical and managerial leadership to anti-tuberculosis activities in the country. As per the National Strategic Plan 2012-17, the program has a vision of achieving a TB-free India and aims to provide universal access to TB control services. The program provides various free of cost, quality tuberculosis diagnosis and treatment services across the country through the government health system. India National Strategic Plan (NSP) for TB start from 2017 up to 2025. The Indian TB National Strategic Plan (NSP) implemented in 2017 up to 2025 is the plan produced by the Government of India which sets out what the government believes is needed to eliminate TB in India. The NSP implemented in 2017 to 2025 describes the activities and interventions that the Government of India believes will bring about significant change in the incidence, prevalence and mortality from TB. This is in addition to what is already going on in the country. Visions and goals of the National Strategic Plan of TB. The vision is of a TB-free India with zero deaths, disease and poverty due to tuberculosis. The goal is to achieve a rapid decline in the burden of TB, mortality and morbidity, while working towards the elimination of TB in India by 2025. The requirements for moving towards TB elimination in India have been arranged in 4 strategic areas of detect, treat, prevent and build. Targets of the National Strategic Plan. The targets of the National Strategic Plan are set out as consisting of both outcome and impact indicators. There are also 4 main thrust or priority areas in the NSP, which are: private sector engagement, plugging the leak from the TB care cascade, i.e. people with TB going missing from care, active case finding among key populations, and for people in high-risk groups, preventing the development of active TB in people with latent TB. Another thrust area is that of the programmatic management of drug-resistant TB, PMDT. National Strategic Plan to End TB in India 2020 to 2025. This NSP is an update of the NSP 2017 to 2025, which is necessitated by the rapidly changing environment within which NTP operates. Knowledge and insights generated from the Joint Monitoring Mission in 2019, 16 large-scale program evaluations, central internal evaluations, during 2017 to 2019, implementation of the past NSP, especially scale-up of private sector involvement strategies, rollout of rapid molecular tests, LTBI, that is latent tuberculosis infection treatment rollout, and updated recommendations from WHO sets the direction for this NSP. The Integrated Disease Surveillance Program is to detect early warning signals of impending outbreaks and help initiate an effective response in a timely manner. It also provides essential data to monitor progress of ongoing disease control programs and help allocate health resources more optimally. Vertical disease surveillance programs focus on a single disease or organism, while horizontal programs focus on multiple diseases or organisms. In global health, vertical programs focus on specific diseases, while horizontal programs focus on the entire health system. Both approaches can be used to detect and respond to outbreaks, but they have different strengths and weaknesses. Vertical programs focus on specific diseases, such as malaria. Benefits can strengthen the health system by sharing resources and improving public perceptions. Horizontal programs focus on the entire health system. Benefits can improve data quality, reduce redundancies, and enable earlier outbreak detection. What is Integrated Disease Surveillance Project, IDSP? A decentralized system of disease surveillance for timely and effective public health action with a focus on functional integration of surveillance components of various vertical programs. This project aims at improving the efficiency of disease surveillance for use in health planning, management and evaluating control strategies. What is surveillance? Surveillance is defined as the ongoing systematic collection, collation, analysis and interpretation of data and dissemination of information to those who need to know in order that action be taken. Surveillance in the Integrated Disease Surveillance Program, IDSP, is a nationwide system that monitors and detects diseases in India. The probable surveillance under IDSP is based on the clinician's assessment of the patient based on signs and symptoms. Timely sharing of this information can help prevent the spread of outbreaks in the community. Important information in surveillance. Depending on the level of reporting of the health staff, disease surveillance under IDSP are of: who get the disease, how many get them, where they get them, when they get them, why they get them, what needs to be done as public health response. Why do we need to do surveillance? Recognize cases or cluster of cases to trigger intervention to prevent transmission or reduce morbidity and mortality. Assess the public health impact of health events or determine and measure trends. Demonstrate the need for public health intervention program and resources during public health planning. Why do we need to do surveillance? Monitor effectiveness of prevention and control measures and prevent outbreaks. Identify high-risk groups or geographical areas to target interventions and guide analytic studies. Develop hypotheses that lead to analytic studies about risk factors for disease causation, propagation or progression. Objectives of Integrated Disease Surveillance Program (IDSP). The key objective of the program is to strengthen and maintain decentralized surveillance system. To identify risk factors for non-communicable diseases, NCDs, and or communicable diseases, CDAs. For timely initiation of public health action. To improvement of efficiency of surveillance activities. For dissemination of relevant information to health administration, community, other stakeholders about disease risk factors, monitoring and evaluation. Program components of Integrated Disease Surveillance Program, IDSP. Integration and decentralization of surveillance activities through the establishment of Surveillance Units at center, state and district level. Human resource development, training of state surveillance officers, district surveillance officers, rapid response team and other medical and paramedical staff on principles of disease surveillance. Use of information communication technology for collection, collation, compilation, analysis and dissemination of data. Strengthening of public health laboratories. Intersectoral coordination for zoonotic diseases. Surveillance strategy in the Integrated Disease Surveillance Project. District level is the basic functional unit for integrating surveillance functions. All surveillance activities are coordinated and streamlined. Resources are combined to collect information from single focal point at each level. Several activities are combined into one integrated activity to take advantage of similar surveillance functions, skills, resources and target populations. Surveillance strategy in the Integrated Disease Surveillance Project. Integrates public and private sector by involving private practitioners and communities. Addresses communicable and non-communicable diseases. Covers both rural and urban health systems. Collaborates with private and public medical colleges. Main objectives of the Integrated Disease Surveillance Project. To establish a decentralized district-based system of surveillance for communicable and non-communicable diseases so that timely and effective public health actions can be initiated in response to health changes in the urban and rural areas. To integrate existing surveillance activities to avoid duplication and facilitate sharing of information across all disease control programs and other stakeholders so that valid data is available for health decision-making in the district, state and national levels. Important components where additional inputs will be provided, which includes strengthening of laboratories, improved information management system, human resource development, developing supporting structure for integration. What is integration? Sharing of surveillance information of disease control programs. Developing effective partnership with health and non-health sectors in surveillance, including communicable and non-communicable diseases in the surveillance system. Working with the private sector and non-governmental organization. Bringing academic institutions and medical colleges into disease surveillance. Classification of surveillance in IDSP. Classified in 3 types. Syndromic surveillance is diagnosis made on the basis clinical pattern by paramedical personnel and members of community. Presumptive surveillance is diagnosis made on typical history and clinical examination by medical officers. And confirmed surveillance is clinical diagnosis by medical officer and/or positive laboratory identification. Conditions under regular surveillance. The following table gives us idea about various type of disease with their example of diseases. For vector-borne diseases, example is malaria. For water-borne diseases, examples are diarrhea, cholera, and typhoid. For respiratory diseases, example is tuberculosis. For vaccine-preventable diseases, example is measles. For disease under eradication, example is polio. For other conditions, example is road traffic accidents. For international commitment, example is plague. For unusual syndromes, examples are meningoencephalitis, respiratory distress, and hemorrhagic fever. Other conditions under surveillance types identified as below. First surveillance type is sentinel surveillance, with its one category is sexually transmitted diseases and it's found in conditions like HIV, HBV, HCV. Second category includes other conditions with conditions like water quality and outdoor air quality. Second type of surveillance is regular surveys, includes category of non-communicable disease risk factors with conditions found in anthropometry, physical activity with blood pressure and tobacco along with blood pressure. Other conditions includes like nutrition and blindness. Third type of surveillance type is additional state priorities, which includes up to any 5 diseases. State-specific diseases given below. For Madhya Pradesh, Uttaranchal-specific diseases are diphtheria, neonatal tetanus, and leprosy. For Maharashtra, specific diseases are diphtheria, neonatal tetanus, and leptospirosis. For Andhra Pradesh, specific disease condition is filariasis. For Karnataka, specific diseases are filariasis, KFD and HGS, and leptospirosis. For Tamil Nadu, specific diseases are leprosy and leptospirosis. For Kerala, specific disease condition is leptospirosis. For Mizoram, specific diseases are cancer, substance abuse, acid peptic disease, and pneumonia. The limited number of conditions under surveillance. Limited number of core diseases for improves quality of surveillance and reduces workload. Diseases of regional importance for under surveillance in addition to the core list. Review and modification of the list according to needs at least once in 2 years. Viral hepatitis and acute respiratory tract infection also under consideration at various levels. May be included subsequently. Reporting units for disease surveillance. Rural places include some public sectors, exhaustive, like community health centers, and district hospitals along with private sectors, sentinel, like practitioners and hospitals. Urban places include some urban hospitals, ESI, railways, medical colleges and private sectors like nursing homes, hospitals, medical colleges and pathological laboratories. Role of district surveillance officers and medical officers. To do supervision and quality control of active surveillance by field staff. To perform passive surveillance for diseases on the list. Supervision of compilation and transmission of periodical reports. Integration of sentinel private practitioners. Emergency response to surveillance reports received. Facilitation of outbreak investigation and response. A functional vision of surveillance include 4 levels or steps. Step 1 is to collect and transmit data. Step 2 is to analyze data. Step 3 is to collect feedback information. Step 4 is to make decisions based on feedback collected. Here all levels or steps use information to make decisions. District Surveillance Committee includes CMO, Co-Chair, Representative Water Board. District Program Manager for Polio, Malaria, TB, HIV AIDS. Superintendent of Police. Chief District Primary Health Center Laboratory. IMA Representative. District Data Manager, IDSP. NGO Representative. Representative Pollution Board. Superintendent of Hospitals. District Training Officer, IDSP. Medical College Representative if any. District Panchayat Chairperson. District Surveillance Officer, Member Secretary. The Integrated Disease Surveillance Program, IDSP, District Surveillance Unit, DSU, is made up of one main Chief Medical and Health Officer. District Surveillance Officer connected with one response team consists of epidemiologist, microbiologist and clinicians. District Surveillance Officer connected with one accountant, one administrative assistant and two data entry operators. A District Epidemic Investigation Team, DATE, investigates and controls outbreaks in a district. They work with local health staff and other authorities to contain the spread of disease. DATE responsibilities confirming and investigating outbreaks, helping local health staff control outbreaks, following up on control measures, coordinating with other agencies, and reporting to the District Surveillance Officer, DSO, and other concerned authorities. An District Epidemic Investigation Team may include epidemiologist, nodal officer, which is directly gets reports from clinician, pediatrician, physician, and microbiologist. Nodal officer is also connected to district administration nominee and support staff including entomologist, health assistants and laboratory technician. Information flow of the weekly surveillance system. The information flow followed to ensure timely reporting of data relating to target diseases is depicted in the schematic diagram given here. The weekly data gives information on the disease trends and seasonality of diseases. Whenever there is a rising trend of an illness in any area, it is investigated by the Rapid Response Teams, RRT, to diagnose and control the outbreak. Data analysis and actions are being undertaken by respective state district surveillance units. Emphasis is now being laid on reporting of surveillance data from major hospitals and also from infectious disease hospitals. Functions of the District Surveillance Unit. For managerial level, it implement and monitor all project activities. It coordinate with laboratories, medical colleges, non-governmental organizations and private sector. It organize training and communication activities, and it organize district surveillance committee meetings. For data handling, collection of centralized data, analyze data with forwarding regular feedback to surveillance unit on weekly basis. For outbreak response, constitution of rapid response teams and investigation of data. The National Leprosy Eradication Program, NLEP, is a health program in India that aims to eliminate leprosy and reduce its disability burden. The program is funded by the Ministry of Health and Family Welfare. National Leprosy Control Program, NLCP, was launched by the Government of India in 1954-55. Multi-drug therapy, MDT, came into wide use from 1982, and the National Leprosy Eradication Program was introduced in 1983. The strategy of NLEP was based on controlling the disease through reduction in the quantum of infection in the population and reduction in infective source, thus breaking the chain of disease transmission. The program was initially taken up in endemic districts and was extended to all districts in the country from 1993 to 1994 with World Bank assistance. 4 research and training institutes were established directly under DGHS, namely Central Leprosy Training and Research Institute Institutes, CLTRI, Chengalpattu, Regional Leprosy Training and Research Institute, RLTRI, at Raipur, Gauripur and Aska. In addition, a training center was established at Agra under ICMR. Remarkable progress has been achieved in reducing the disease burden in the country. Vision of National Leprosy Eradication Program is Leprosy-Free India. The NLEP's mission is to provide quality leprosy services free of cost to all sections of the population with easy accessibility through the integrated healthcare system, including care for disability after cure of the disease. Objectives of National Leprosy Eradication Program: to reduce prevalence rate less than 1 by 10,000 population at sub-national and district level. To reduce grade to disability %1 among new cases at national level. To reduce grade to disability cases 1 case per million population at national level. Zero disabilities among new child cases. Zero stigma and discrimination against persons affected by leprosy. Strategy of National Leprosy Eradication Program. To achieve the aforementioned objectives, the main strategies to be followed are: 1. Integrated anti-leprosy services through general health care system. 2. Early detection and complete treatment of new leprosy cases. 3. Carrying out household contact survey for early detection of cases. 4. Involvement of accredited social health activist, ASHA, in the detection and completion of treatment of leprosy cases on time. 5. Strengthening of disability prevention and medical rehabilitation, DPMR, services. 6. Information, education and communication, IEC, activities in the community to improve self-reporting to primary health center, PHC, and reduction of stigma. And 7. Intensive monitoring and supervision at health and wellness centers and block primary health center community health center. Program components of National Leprosy Eradication Program: case detection and management, disability prevention and medical rehabilitation, DPMR, information, education and communication, IEC, including behavior change communication, BCC, human resource and capacity building, program management. Salient features of the National Leprosy Eradication Program are: Leprosy Eradication Program is a centrally sponsored scheme of Government of India. NLEP functions under the umbrella of National Health Mission, NHM. NLEP follows decentralized health planning and funds are sent to the states through state health societies. Quality of services and sustainability is the main focus. Disability prevention and medical rehabilitation, DPMR, is a priority. Removal of stigma and discrimination is a part of the strategy. Activities carried out under NLEP: diagnosis and treatment of leprosy, capacity building, IEC and counseling, disability prevention and medical rehabilitation, supervision and monitoring, NGO services under set scheme. New initiatives: enhanced active and early case detection strategy has been introduced through ACD and RS, active case detection and regular surveillance strategy throughout the year. Convergence of leprosy screening for targeting different age groups like under RBSK, Rashtriya Bal Swasthya Karyakram, for 0 to 18 years, RKSK, Rashtriya Kishore Swasthya Karyakram, 13 to 19 years, and CPHC, Comprehensive Primary Health Care, Ayushman Bharat, above 30 plus virus population. Timely referral and follow-up for treatment completion on time through multi-drug therapy, MDT, available free of cost in all public health facilities. New initiatives: for prevention of leprosy amongst contacts, post-exposure chemoprophylaxis administration, PEP. Awareness activities, Routine IEC activities are conducted by states and districts throughout the year. Special annual mass awareness campaigns named Sparsh Leprosy Awareness Campaigns, SLAC, were launched on 30th January 2017, that is, Anti-Leprosy Day, to reduce stigma and discrimination against persons suffering from leprosy. Sapna is a concept, mascot, designed and developed using a common girl living in community, who will help spread awareness in the community through key IEC messages. Sapna can be local school-going girl who is willing to be Sapna. There can be any number of Sapnas in a village. The National Mental Health Program, NMHP, was launched in 1982 to improve access to mental health care for all. Introduction to the National Mental Health Program, NMHP. World Health Organization defines the mental health as a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stressors of life, and can work productively, and is able to make a contribution to his or her community. The Director General, World Health Organization, launched the Mental Health Action Plan 2013 to 2020 on 7 October 2013. The action plan recognizes the essential role of mental health in achieving health for all people. It aims to achieve equity through universal health coverage and stresses the importance of prevention in mental health. Aim of the National Mental Health Program, NMHP. It aims to achieve equity through universal health coverage and stresses the importance of prevention in mental health. Objectives of the National Mental Health Program, NMHP. The objectives of World Health Organization Mental Health Action Plan 2013 to 2020 are: more effective leadership and governance for mental health, the provision of comprehensive, integrated mental health and social care services in community-based settings, implementation of strategies for promotion and prevention, strengthened information systems, evidence and research for mental health. Indian scenario, history of the National Mental Health Program, NMHP. The Bhore Committee report in 1946 stated that the prevalence of mental illness during that period was estimated to be 2 of 1,000 general population, and India had only 10,000 psychiatric beds and 30 institutions for a population of over 400 million. The Government of India appointed Health Survey and Planning Committee in 1959, chaired by Dr. Mudaliar, to assess the state of health care and review the progress after the implementation of Bhore Committee's recommendation. Indian scenario, history of the National Mental Health Program, NMHP. The Srivastava Committee recommended that Community Health Volunteer (CHV) scheme. CHV were supposed to provide their services to a population of 1,000. The committee recommended that the training of community health volunteers should have a component on mental health. The National Institute of Mental Health and Neurosciences, NIMHANS. Some new mental hospitals were started, and All India Institute Mental Health was set up in 1954, which later became NIMHANS in 1974. The concept of community psychiatry was initiated by Central Institute of Psychiatry, CIP, Ranchi, by starting a rural mental health clinic in 1967 at Mandar. Major community mental health initiatives were taken at NIMHANS Bangalore and PGIMER Chandigarh during 1970s. Community Psychiatry Unit was established by NIMHANS. Objectives: to ensure the availability and accessibility of mental health care for all in the foreseeable future, particularly to the most vulnerable and most underprivileged sections of the population. Encourage applications of mental health knowledge in general health care and social development. promote community participation in mental health services development and stimulate efforts towards self-help in community. Strategies: integration of mental health with primary health care through the NMHP. Provision of tertiary care institutions for treatment of mental disorders. Eradicating stigmatization of mentally ill patients and protecting their rights through regulatory institutions like the Central Mental Health Authority, CMHA, and State Mental Health Authority, SMHA. The National Program for Prevention and Control of Deafness, NPPCD, is a program by the Government of India to prevent and treat hearing loss and deafness. The program includes screening camps, medical treatment, and rehabilitation services. Introduction. Hearing loss is the most common sensory deficit in humans today. World over, it is the second leading cause for years lived with disability, YLD, the first being depression. As per WHO estimates in India, there are approximately 63 million people who are suffering from significant auditory impairment. This places the estimated prevalence at 6.3% in Indian population. As per National Sample Survey Office, NSSO, survey, currently there are 291 persons per 1 lakh population who are suffering from severe to profound hearing loss. Of these, a large percentage is children between the ages of 0 to 14 years. With such a large number of hearing impaired young Indians, it amounts to a severe loss of productivity, both physical and economic. An even larger percentage of our population suffers from milder degrees of hearing loss and unilateral, one-sided, hearing loss. Types and effects of hearing impairment. Hearing impairment, including deafness, may be sensorineural, due to damage to the inner ear or the auditory nerve. Conductive, due to blockage or reduction of sound waves passing through the outer or middle ear, or a mixture of the two. They have a profound effect on individuals. They may delay development of speech and language, slow educational progress, cause difficulty in obtaining, performing and keeping a job, cause social problems, and lead to being stigmatized, unfairly thought of as undesirable or discreditable, at all ages. Objectives of the program. To prevent the avoidable hearing loss on account of disease or injury. Early identification, diagnosis, and treatment of ear problems responsible for hearing loss and deafness. To medically rehabilitate persons of all age groups suffering with deafness. To strengthen the existing intersectoral linkages for continuity of the rehabilitation program for persons with deafness. To develop institutional capacity for ear care services by providing support for equipment and material and training personnel. Components of the program. Manpower training and development for prevention, early identification and management of hearing impaired and deafness cases. Training would be provided from medical college level specialists, ENT and audiology, to grassroots level workers. Capacity building for the district hospital, CHC and PHC in respect of ENT audiology infrastructure. Service provision including rehabilitation, screening camps for early detection of hearing impairment and deafness, management of hearing and speech impaired cases and rehabilitation, including provision of hearing aids at different levels of health care delivery system. Awareness generation through IEC activities for early identification of hearing impaired, especially children, so that timely management of such cases is possible. Aid to remove the % stigma attached to deafness. And finally, monitoring and evaluation. Expected benefits of the program. The program is expected to generate the following benefits in the short as well as in the long run. Large-scale direct benefit of various services like prevention, early identification, treatment, referral, rehabilitation, etc. for hearing impairment and deafness as the primary health center. Community health centers, district hospitals largely cater to their need. Decrease in the magnitude of hearing impaired persons. Decrease in the severity extent of ear morbidity or hearing impairment in large number of cases. Improved service network for the persons with ear morbidity hearing impairment in the states and districts covered under the project. Awareness creation among the health workers, grassroots level workers, through the primary health center medical officers and district officers, which will percolate to the lowest level as the lower level health workers function within the community. The National Program for Prevention and Control of Deafness, NPTCD, aims to reduce hearing impairment and deafness. The program's benefits include larger community participation to prevent hearing loss through Panchayati Raj institutions, Mahila Mandals, village bodies, and also creation of a collective responsibility framework in the broad spectrum of the society. Leadership building in the primary health center, medical officers, to help create better sensitization in the grassroots level, which will ultimately ensure better implementation of the program. Capacity building at the district hospitals to ensure better care. State-of-the-art Department of ENT at the medical colleges in the state union territory under the project. The National Program for Prevention and Control of Deafness, NPPCD, in India has an organizational structure that runs from the central level to the state and district levels. The NPPCD's organizational structure monitors and implements activities to reduce hearing loss in India. The Universal Immunization Program, UIP, is a public health program that provides free vaccines to children and pregnant women against vaccine-preventable diseases. It is one of the largest and most cost-effective public health programs in India. India's immunization program is one of the largest public health programs in the world. Launched as Expanded Program on Immunization in 1978, it was renamed as Universal Immunization Program in 1985 when it was expanded beyond urban areas. It targets 3.04 crore pregnant women and 2.7 crore newborns annually. More than 1.2 crore immunization sessions are being conducted annually. Under UIP, immunization is being provided free of cost against 12 vaccine-preventable diseases includes nationally against 11 diseases: diphtheria, pertussis, tetanus, polio, measles, rubella, severe form of childhood tuberculosis, rotavirus diarrhea, hepatitis B, meningitis and pneumonia caused by Haemophilus influenza type B and pneumococcal pneumonia, and subnationally against one disease, Japanese encephalitis. J vaccine is provided only in endemic districts. The vaccination schedule under the UIP is given below. The vaccination schedule for pregnant women under UIP is given below. All the due vaccines can be given at the same time but in different sites. The stated objectives of UIP are to rapidly increase immunization coverage, to improve the quality of services, to establish a reliable cold chain system to the health facility level, monitoring of performance, to achieve self-sufficiency in vaccine production. Achievements. The biggest achievement of the immunization program is the eradication of smallpox, 1977. One more significant milestone is that India is free of poliomyelitis, 2014, caused by wild polio virus, WPV, the last recorded case being in 2011. Elimination of maternal and neonatal tetanus in 2016. Vaccination has contributed significantly to the decline in the cases and deaths due to the vaccine-preventable diseases, VPDS. The program's name was changed from the National Program for Control of Blindness to the National Program for Control of Blindness and Visual Impairment, NPCBVI, in 2017. The National Program for Control of Blindness and Visual Impairment, NPCBVI, is a program that aims to reduce the prevalence of blindness in India. The program was launched in 1976. Definition of blindness. WHO definition. Visual acuity less than 3/60ths, Snellen's, or its equivalent. NPCB definition. Inability of a person to count fingers from a distance of 6 meters or 20 feet. Vision 6/60ths or less with the best possible spectacle correction. Diminution of field vision to 20 degrees or less in better eye. Types of blindness. Visual impairment is a general term for any vision loss that interferes with daily activities. There are several types of blindness, including economic blindness, social blindness, manifest blindness, absolute blindness, curable blindness, preventable blindness, and avoidable blindness. A Snellen chart is an eye chart that measures visual acuity. It's the most common eye chart used by eye care professionals. How it works. Stand 20 feet from the chart. Cover one eye and read the smallest line of letters you can see. Repeat with the other eye. What it measures. The Snellen chart uses a geometric scale to measure visual acuity. Normal vision is 20/20ths. For example, if you can read the line of letters that someone with normal vision can read from 40 feet away, your vision is 20/40ths. Introduction to National Program for Control of Blindness, NPCB, in India. India was the first country in the world to launch national-level blindness control program. In 1976, NPCB launched as 100% centrally sponsored program. From 1994 to 1995, program decentralized with formation of District Blindness Control Society, DBCS, in each district. Aim of National Program for Control of Blindness, NPCB, in India. To reduce the prevalence of blindness from 1.49%, 1986 to 89, to less than 0.3% by 2020. To establish an infrastructure efficiency to cater new cases of blindness each year to prevent future backlog. Objectives of National Program for Control of Blindness, NPCB, in India. To reduce the backlog of avoidable blindness through identification and treatment. Eye health for all through provision of eye care services. Strengthening and upgradation of regional institutes of ophthalmology, RIOS, and additional human resources and infrastructure facilities. To enhance community awareness on eye care and lay stress on preventive measures. Increase and expand research for prevention of blindness and visual impairment. To secure participation of voluntary organizations, private practitioners in eye care. Strategies of National Program for Control of Blindness in India. Continued emphasis on free cataract surgeries. Emphasis on diabetic retinopathy, glaucoma, corneal transplantation, vitreoretinal surgeries, childhood blindness. Active screening of population above 50 years of age. Screening of school children for identification and treatment of refractory errors. Coverage of underserved areas for eye care through public-private partnership. Capacity building of health personnel. IEC activities for community. Strengthening of Regional Institute of Ophthalmology, RIOs, and medical colleges of states and district hospitals. The specially designed mobile unit is air-conditioned and fully equipped with a slit lamp, visual field analyzer, digital fundus camera, laser, and generator. This is identified as Project Nayantara. In another picture there is a local ophthalmologist receives hands-on training inside in the mobile truck. Organizational structure of National Program for Control of Blindness. The National Program for Control of Blindness, NPCB, in India has a three-tier structure at the central, intermediate, and peripheral levels. The NPCB has a District Blindness Control Society, DBCS, and a State Blindness Control Society, SBCS. At district level. Chairman who is District Collector or District Mission Director. Vice Chairman who is Chief Medical and Health Officer or District Health Officer. Member Secretary who is Deputy CMO or an ophthalmologist. Technical Advisor who is Chief Ophthalmic Surgeon of the District Hospital. Members who is Medical Superintendent or Civil Surgeon of the District Hospital. At state level. State Blindness Control Society merged with State Health Society under the National Rural Health Mission, NRHM. NPCB's goals reduce the prevalence of blindness, expand eye care services, establish permanent infrastructure, intensify eye health education, and eliminate avoidable blindness by 2020. The Pulse Polio Immunization Program is a vaccination campaign in India that aims to eradicate polio. It was launched in 1995. Pulse Polio is an immunization campaign established by the Government of India to eliminate poliomyelitis, polio, in India by vaccinating all children under the age of 5 years against the polio virus. The project fights polio through a large-scale Pulse vaccination program and monitoring for poliomyelitis cases. Vellore, Tamil Nadu, was the first Indian town to become 100% polio-free through the Pulse strategy, and rest of India adopted the strategy in 1995. In 1985, the Universal Immunization Program, UIP, was launched to cover all the districts of the country. UIP became a part of Child Survival and Safe Motherhood Program, CSSM, in 1992 and Reproductive and Child Health Program, RCH, in 1997. This program led to a significant increase in coverage, up to 5%. The number of reported cases of polio also declined from thousands during 1987 to 42 in 2010. In 1995, following the Global Polio Eradication Initiative of the World Health Organization, 1988, India launched Pulse Polio Immunization Program with Universal Immunization Program which aimed at 100% coverage. The last reported cases of wild polio in India were in West Bengal and Gujarat on 13 January 2011. On 27 March 2014, the World Health Organization, WHO, declared India a polio-free country, since no cases of wild polio been reported in for 5 years. Introduction of polio vaccine in India. Polio vaccines are vaccines used to prevent poliomyelitis, polio. Two types are used, an inactivated poliovirus given by injection, IPV, and a weakened poliovirus given by mouth, OPV. The World Health Organization, WHO, recommends all children be fully vaccinated against polio. Aim of Pulse Polio Program in India. May 1998, the World Health Assembly committed the members of the World Health Organization, WHO, to achieving the aim of global eradication of poliomyelitis. This goal is defined as no cases of clinical poliomyelitis associated with wild polio virus. No wild polio virus found worldwide despite intensive efforts to do. Objectives of Pulse Polio Program in India. The Pulse Polio Initiative, PPI, aims at covering every individual in the country. It aspires to reach even children in remote communities through an improved social mobilization plan. Not a single child should miss the immunization, leaving no chance of polio occurrence. Cases of acute flaccid paralysis, AFP, to be reported in time and stool specimens of them to be collected within 14 days. Outbreak response immunization, ORI, to be conducted as early as possible. Maintaining a high level of surveillance. Performance of good mop-up operations where polio has disappeared. Acute flaccid paralysis, AFP, is a rare but serious condition that causes muscle weakness or paralysis in the limbs, face, and muscles used for breathing and swallowing. It can be caused by many infectious and non-infectious conditions. Steps involved in Pulse Polio program in India. Setting up of booths in all parts of the country. Initializing walk-in cold rooms, freezer rooms, deep freezers, ice-lined refrigerators and cold boxes for a steady supply of vaccine to booths. Arranging employees, volunteers and vaccines. Ensuring vaccine vial monitor on each vaccine vial. Immunizing children with OPV on National Immunization Days. Identifying missing children from immunization process. Surveillance of efficacy. The primary strategies for achieving eradication of polio are attaining high routine immunization. 3 routine OPV doses should be received by infants at ages 6, 10 and 14 weeks. National Immunization Days. Mopping up immunization. Role of community health nurse. Educate the parents on the following concepts in order to achieve the goal. Even sick and newborn children are to be given polio drops. These drops are in addition to routine immunization doses. These drops are completely safe and are of highest quality. Repeated doses provide additional protection. Role of community health nurse. Routine polio vaccination at birth, 6 weeks, 10 weeks and 14 weeks of age is also essential. Polio eradication efforts will continue till we achieve the goal of polio eradication. Maintain cold chain while vaccinating and check for potency of the vaccination. Take active part in identifying case of AFP, acute flaccid paralysis.